So with no further ado, I will introduce again Dr. Jackson, who is Clinical Associate Professor within Division of Hematology at St. Paul's at UBC. She got her MD from the University of Calgary and then stayed there as a hematology resident and then a Bayer International Hemophilia Scholarship Hemostasis Fellowship there. Her research interests are in the individualization of prophylaxis, bleeding and collagen vascular disorders, and the impact of aging on hemophilia. She's medical director of the BC Provincial Adult Hemophilia Program at St. Paul's. She's also currently the president of the AHCDC and also the chair of the Prophylaxis Committee. And she's going to speak to us today on can we extend far enough extended half-life factor 8 and 9 concentrates. So, thank you, Shannon.
Thank you very much, Jason, and to all of you. So I decided to ask a question because I don't have a lot of time. So I may raise more questions than I actually answer for you this morning. And here are my speaker disclosures. So in the brave new world, we're sitting on a landscape where we've been in a comfortable place on our island of factor concentrate replacement, having a safe, effective, and secure supply for over 20 years. And as we look out on the landscape, there's a number of exciting treatments that are going to come our way. And I'm fortunate to be beside many esteemed colleagues who are going to talk about them later in this session. What I'm going to do is stay within the factor replacement zone and talk really specifically about extended half-life or EHL products and focus my time, because I only have 15 minutes, on the currently available products in Canada. So my talk will be divided in two. The initial part will just be to give you some background for those of you who don't know much about products in Canada that have been used in just over a year. And then the last part of my talk, I'm going to give you some information about our early utilization that we've observed. What I'm not going to talk about today is products not in Canada yet. And I'm not going to talk about some of the products that were developed under the standard half-life category, but have been reported to have mid-range half-lives, longer half-lives than historically. So by way of a simple introduction, which isn't really that simple after all, half-life extension technology has been a major focus of hemophilia research for at least 10 to 15 years. Right now, we have two major strategies that have been effective, and that's resulted in the marketing of many products across the world and many ongoing clinical trials and studies. They're divided into fusion proteins and pegylation, and they don't just have application in our field. There's many, many different medical fields where these products have been used. Fusion protein, namely the FC fusion protein, is the only product we have in Canada that is being carried by Canadian Blood Services at this time. So I'm going to focus on that due to the shortness of my presentation. So to obtain a longer half-life, it's necessary to slow the clearance naturally through the body. And both of the fusion proteins use a process that is known as the endogenous IgG recycling pathway. And what naturally happens in humans and mammals is that the body aims to take and sample small amounts of plasma from the blood or blood from the circulation through the endothelial cells and then process that and basically sort it into, I want to keep this because it's taken me a lot of energy to produce this, or I want to discard this. And so through this system, the research has capitalized on using and fusing specific proteins to factor 8 and factor 9, namely an FC domain of an immunoglobulin molecule or a recombinant albumin portion. And when fused to a recombinant factor 8 or factor 9 protein, this allows the product. I don't have a pointer. So it allows this fusion product to interact with that little green figure there called the neonatal FC receptor. And as soon as there's binding with either the fusion component or the albumin component, that whole complex is actually recycled and then released back out into the circulation. If a protein remains free or unbound, it generally gets destroyed within the cell. So this is how the industry has capitalized on allowing what would normally be a fairly predictable clearance to be extended because of this recycling that's ongoing in the blood. The two products in Canada that are of this type are factor VIII FC, otherwise known as Eloctate, and factor IX FC, otherwise known as Alprolix. These products were actually licensed in Canada back in 2014, and they were licensed on the basis of pivotal, very large adult and pediatric phase 3 clinical trials that were conducted worldwide. There was some Canadian patients, and these trials were conducted only in patients who were previously treated quite a lot with factor concentrates. So depending on the study and the age group, anywhere from 50 to 150 or more exposure days. I'm not going to be speaking of the ongoing trials in relatively untreated patients today. I'm going to be speaking of the previously treated patients because this was the background that led to the licensing and ultimately the use in Canada. These trials were big. There was a lot of portions studied, including the pharmacokinetic behavior of these products, because that's obviously the premise of trying to prolong the half-life with an aim to increase the time or the interval between infusions. They were studied in prophylaxis and specifically in individualizing prophylaxis, so ways to capitalize on the potential that you could infuse potentially less often or have larger increments between the infusions. And of course, they were all studied in patients who don't use prophylaxis and those who treat bleeds on demand and under the conditions of surgery, because those are all real world type of situations. So to summarize what all of the trials basically found was there was no concerns with respect to safety that came out of those trials or the subsequent extension studies, no cases of neutralizing inhibitor in that population, nor any factor-related thrombotic events. And in general, a similar infusion experience was reported between those products and the standard factor VIII or factor IX products. In terms of efficacy, which is a very important outcome as well, approximately 90% of bleeding episodes reported in those studies were treated with one dose of factor concentrate effectively. And around surgery, good to excellent results were seen based on clinician report. Efficacy in terms of prophylaxis is an important outcome measure that was also studied. And just to summarize, on the table on the left is for factor VIII FC, that looks at the bleeding rates reported on individuals who had prophylaxis anywhere between twice a week or once every 3 to 5 days over a 3-year period. So the patients who are reflected in that graph have been on the product a median of about 3 years. And it's showing low rates of spontaneous bleeding on prophylaxis and also stable rates of bleeding. Looking over to the right is a table derived from the factor IX study, the extension study, which using prophylaxis regimens varying from once a week to individualized, which could be once a week or once every 2 weeks, or modified prophylaxis. Low bleeding rates were also observed, and in general, those have been stable. So why is all that possible? Well, it gets into the science of pharmacokinetics, which is much more complicated than we have a lot of time to discuss today. But what you'll see out there in terms of the EHL products is a discussion of comparisons of half-life, of actually the mean half-life, or in this case, the mean geometric half-life. And in general, the comparisons that you'll see are between factor VIII FC or even another type of extended factor VIII and a standard product. In the case I've got on the slide, we're talking about Eloctate compared to Advate. And in the phase 3 trial, as well as in phase 2 trials, a number of selected patients, in this case adults, underwent fairly intensive pharmacokinetic sampling. So anywhere from 6 blood time points after an infusion all the way up to 12 to really characterize the behavior of these proteins, and to do so by comparing one protein in the same patient. So that's where the data came from to tell us that the half-life, at least from a mean perspective, was 19 hours for factor VIII FC, and the measured half-life for the standard product, in this case Advate, was 12 hours. Looking over to the factor IX scenario, you can see that the half-life measured was 82 hours for the factor IX FC and 34 hours for the comparator product, which was a Benefix. And that is a little bit different than some of you may remember, but the numbers that are derived are really based on the intensity and length of the pharmacokinetic sampling protocol. So head-to-head, that's where they got the threefold difference. And many of us remember the threefold difference. It also applies in most cases to the pediatric population. And I'm sorry if that has fallen off the slide, but just to reflect with you, there is data in the pediatric population with slightly shorter half-life reports, as is the case with standard factor VIII, between 13 and 15 hours for factor VIII FC and 64 to 70 hours for factor IX FC. And I've introduced in the slide a little bit of the confidence intervals to give you a flavor that not every patient is going to have a half-life of 19 hours or 12 hours for that matter for factor VIII. So what that gets into is how do you have conversations about this in your clinic? This is not necessarily easy information for patients to digest. It doesn't really mean anything, all that I've shown you so far. So sometimes if we look at it a slightly different way, it can make a lot more sense. So this is a conceptual diagram that I've created. It's a standard thing used in pharmacokinetics called a concentration versus time curve. And the vertical axis will show you the concentration of factor VIII in this case. And this is a short-acting factor VIII model. And the bottom axis shows you time. And another way to look at half-life is to look at what is the change in the factor level over time after an infusion. And the two red bars really reflect what the distribution in the population would look like. So in most cases, patients will be in between those two red lines. Patients with a shorter half-life, let's say, for example, something like 9 hours, will be on the lower curve. And if you pick kind of an arbitrary factor number, let's say 2% is just an arbitrary number, and you actually can read that green line over and say, that person took 40 hours to get to 2%. And then you go, well, what about the other patient? So looking at the patient who had the other curve, it took that patient 84 hours to reach the same outcome. And I think that starts to show a little bit about the variability in a way that we can actually understand, because these are numbers that can inflect on our decisions about when to give another dose of prophylaxis. And variability is inherent to factor VIII and factor IX. So we know from prior studies that there can be a threefold difference in the half-life from the lowest or the shortest to the longest half-life. And that is just part of working with humans and factor VIII or factor IX. So what happens with the EHL products then? Well, a similar thing, although you see things shifted on this conceptual diagram over to the right. So we still have a variability. And when we looked at this just recently within the WAPS program, there is a threefold difference as well in patients on at least the FC product. So this is something that is part of our clinics. And the only way we're actually going to be able to read this or recognize this is through doing either trough levels or population pharmacokinetic studies. Now, you'll sort of notice that there's a little bit of a zone in between, sort of this zone where you could actually have one patient who has a time to 2% on a standard factor product that's actually the same as a different patient who has the same time to that 2% level on an extended half-life product. So what I'm saying is that the variability really is real, and the new products give us opportunities to enhance our ability to individualize, but perhaps we need to understand on an individual level what that means. So variability is a fact of life, too. All of you will appreciate in this room that none of these patients are exactly alike. Within each age group, you're going to have a lot of variability between patients in terms of their physical activity, their existing joint health, their bleeding phenotype, their ability to participate in sports. Even their philosophy and approach to life is going to be very different. And of course, one patient going through this spectrum of life is going to change their needs dramatically along the way. So we already do this. We already develop a prophylaxis regimen, say for these guys who might be in my clinic. We already developed that almost without measuring those things. And the product we use and the half-life of that product is part of it, but it's not always the only thing that we use to make an adjustment. And so, for example, in my clinic, the hemophilia A patients with the frequency of their prophylaxis regimen there in red are going to be very different from one another. And we might even change that between summer and winter, depending on what's going on. And then some of my older patients, they could be on daily, depending on their activity, or they could be on weekly treatment. It really, really just depends. And where I want to say is this variability is an opportunity to actually really tailor the treatment, but it's really based on outcomes and goals for that specific individual. And we're doing it without even really measuring it in some cases. Health-related outcomes are typically things that we report, as I did, in studies that are done, mandated by health regulatory agencies. But we're already doing this. We're collecting outcomes on bleeding rates. We're collecting outcomes on pain, but we're not always making it a formal process. And I think that when we have a new product available, we really need to start to think about measuring these outcomes as the brave new world changes, because there's going to be even more potentially that we can use to individualize treatment. We're doing a study in Canada involving 8 centers looking at patients who either have switched to a factor VIII FC product or those patients who remain on their standard product, and looking at some of these outcomes in a more realistic way that's not as rigorous as a clinical trial. So we're trying. And now that we've had that little nugget, we're going to take a little bit of a leap into the final part of my presentation, where I want to talk a little bit about what's happened in Canada since the products were introduced. So as I mentioned, in 2014, we had licensure of both the EHL products that I mentioned. They didn't really reach the clinics, though, until 2016. And coincidentally, there was actually a lot of action going on in Canada at that time outside of Quebec because of national product tenders that necessitated a shift or a change in product. So there was a lot of things going on at once. And I'll just sort of tell you how we landed, at least for the first little bit. Before I do, there's criteria that were developed in Canada by the National Advisory Committee for Blood and Blood Products through CBS with some advisement from HCDC. And essentially, these were created to provide the optimal patients or the ideal recommended patients who could be, but didn't necessarily have to go on EHL products. These were patients who would otherwise need a central line if they didn't switch. They had less than expected of a half-life of a standard factor, or outside of Quebec, we had these criteria for patients either on prophylaxis or on demand. And in general, the idea was if you could improve something for a patient who's already on prophylaxis with a standard factor, such as their compliance, their quality of life, or decrease their bleeds, they may be a candidate for this type of treatment. Or if they were on demand with standard factor and prophylaxis with an EHL could improve their bleed rate, then they were a candidate. A couple of things that's important to know with this criteria is that patients who switched were supposed to be from hemophilia clinic treatment centers, and they were supposed to record infusions and bleeds in a monitoring system such as MyCBDR or in BC iChip. So I have a little bit to share with you about the Canadian experience. This was compiled last fall by primarily Arun Kapansaril from McMaster, and he did so much work, and the association actually did so much work to bring together this early information, which was the first ever, that we went ahead and wrote a letter to the editor in Hemophilia that should be out in the next week, I think. And what it really does is summarize in 15 centers from 8 provinces, obviously outside Quebec because those criteria weren't in place there. 139 switches in those clinics happened in that 8-month period of time. 70% of those switches were in pediatric patients. 54% of the pediatric patients were all from one center. In that center, patients generally who had factor VIII deficiency decreased their infusions by 1 per week. So if they were infusing, an average of 3 times per week, they would go down by 1 per week. And those who were infusing factor IX products decreased from 2.5 times per week down to once per week. So that's the amount of data we have for that sort of frequency change. Most of the patients had factor VIII deficiency and were severe. About 80% of the switches were in that group. And almost all patients were on prophylaxis prior to their switch. I've listed there, based on the criteria, the reason for switch. Obviously, we collected the reasons long after the switch happened, so there's not a lot of fidelity to the actual reasons, but clinicians called 70% of the switches on the basis of improvement in quality of life, and the remainder to improve compliance or decrease bleeds on prophylaxis. Everybody wanted to know about utilization. Would utilization increase, decrease, or stay the same? And when these products were negotiated, they were done so at a cost neutrality to the existing products at that time. So this was the utilization data we had based on units per kilo per week. It's for a subset of patients. 2/3 of these are pediatric. And what was learned is that for the patients who had severe hemophilia A, that we had 6 months of data going into the switch, they were using approximately 100 units per kilo per week. And at the time of switch, they were predicted to use about 82 for an overall drop of 20% predicted. Going over to the hemophilia B group, you see a bigger drop from 105 units per kilo per week pre to about 50 units per kilo at the time of switch. Both of these values at the time of switch are comparable to some of the data seen for utilization across a pediatric and adult population. And in the hemophilia B group, it was about a 50% decrease in utilization predicted. So in conclusion, can we extend far enough? I think in this morning's very brief presentation, I've shown you that we have products that are looking promising. I can tell you there's more coming in both categories. There's going to be more biotechnology to try and further extend the half-lives. So who knows how far we'll be able to extend these half-lives. But I think the issues go beyond that in terms of, can we extend ourselves to actually start measuring outcomes and value? Value isn't always cost saved. Value is the ability to have an outcome that you like over the cost. And I think that's how we need to shift our changing over from a cost per unit perspective. Michael Porter wrote a really good article, a piece in New England Journal that's worth reading. Can we extend ourselves far enough in Canada to have all the products that are going to be licensed in Canada in a system with national tenders? I'm not sure. We're going to have to make some decisions. And finally, can we extend ourselves far enough to understand the role of these products in combination with some of the emerging new therapies that you're going to hear about next? Thank you.